Well, so now I'm going to talk about the initial results of the CART19-BE-01 trial, which is an open academic trial on the administration of ARI-01 cells in patients with acute lymphoblastic leukemia and other CD19 lymphoproliferative disorders. So this is a clinical trial, which is a pilot, open-label, non-randomized prospective clinical trials with 2 centers included, one for adults and one for kids, with a target population of patients with relapsed refractory CD19 positive B-cell malignancies, without therapeutic options, and the life expectancy shorter than 2 years. So this trial, the primary endpoint of this trial was safety, both at day +100 and 1 year. As for procedure-related mortality and grade 3 and 4 adverse events, and secondary endpoints was efficacy, also day +100 and 1 year. As for overall and complete response rate, progression-free survival, overall survival, and duration of response. So this trial initially started with 10 patients, but was later expanded to 54. So inclusion criteria included ALL, Non-Hodgkin lymphoma, and CLL patients with ages that ranged from 2 to 80 years, and ECOG performance status that was less than 3. And exclusion criteria was mainly gross CNS involvement, even though CNS 1 and 2 were allowed. Also active systemic immunosuppressions, active GVHD, and also active infections or severe concomitant disorders or organic dysfunction. So for the CRS grading scale, we used the scale proposed by Lee, and for other toxicity assessment, we used the CTCAE 4.0. So ARI-01 cells are autologous T cells that are transduced with a second-generation CAR construct composed by the 4-1BB and CD3 zeta co-stimulatory domains. And for the cell production, we use the Clinimax Prodigy platform. So we recruited 58 patients, of which 54 were proceeded to apheresis, and finally 47 of them were infused with the CAR-T cells. So as for the baseline patient characteristic, we treated 38 ALL patients, of which 11 were kids, with a median age of 24 years, with also a median of 4 prior treatment lines, of which blinatumomab was present in 24%, inotuzumab 34%, and 87% had at least 1 prior allogeneic stem cell transplant. Also, Non-Hodgkin lymphoma, we treated 8 patients with a median age of 47 years and a median of 6 prior treatment lines. So they were all very heavily pretreated patients. Conditioning was pretty standard. We used low doses of fludarabine and cyclophosphamide. For CAR-T cell dosing, we infused a median of 1 million CAR-T cells per kilo. At the beginning, we started infusing all the cells in one single day. But after successfully treating 16 patients due to 3 procedure-related mortality events, we made a second amendment to our protocol, which allowed us to give the cells in 3 different days, on day 0, +1, and +2, giving 10, 30, and 60% of the dose. Also, we advanced the tocilizumab administration from grade 3 to grade 2 CRS. So after this, we could say that any grade adverse events were pretty similar between ALL and non-Hodgkin lymphoma patients. They were mainly cytopenias and hepatic enzymes increase, which were almost present before CAR-T cell infusion. And as for adverse events of special interest, we might say that the incidence of severe CRS dropped from almost 27% in the single diffusion cohorts to 4% after the fractionating of the CAR-T cells. On the other hand, ICANS didn't seem to be much affected by this type of administration, with an incidence of severe ICANS that was less of 3% in all patients. So what we saw in the non-Hodgkin lymphoma patients was pretty similar. We saw a significant decrease on the incidence of severe CRS from 33 to 20% after the fractionated of the infusion. And again, we saw no case of severe ICANS in these patients. As for ARI-1 cell expansion, we did not see any clear difference between both types of administration, but as for CRS, we did see a dramatic change. Fractionating the ARI-1 cells flattens the curve of CRS, lowering its incidence, its severity, and also delaying its onset. And also CRS was shorter in those patients that received the fractionated dosing. And finally, efficacy. As for patients treated with ALL, we saw a complete response rate MRD negative at day plus 28 of 85%, which at day plus 100 was 71%. Median PFS was 12 months, and the median duration of response was almost 15 months. Also, median overall survival was 20 months among all ALL patients. So efficacy didn't seem to be affected by the type of administration. Both PFS and OS are pretty similar in both types of administrations, but we did see a difference of the quality of the response in pediatric patients versus adult patients. So the median PFS of pediatric patients was 18 months versus 9.4 months for the adult populations. Also, the chance to maintain the response at 1 year was 100% in the pediatric population, whereas for adults was 46%. Finally, in efficacy and in the Non-Hodgkin lymphoma and the CLL patient, we might say that diagnoses were too diverse to make conclusions, but we saw an overall response rate of almost 78% in these patients, with a complete response rate of 55% at day plus 100. So after this, we might say that ARI-1 cells showed in this trial a safety and efficacy profile that we believe that remains in line with other academic or commercially available products, even though we think there is potential room for further safety improvement using the fractionated dosing. Also, this data is currently under the evaluation of the Spanish medicines agencies for a possible hospital exemption authorization, and a confirmational multicenter phase 2 clinical trial for relapsed refractory ALL patients. It's about to start. So that will be one resume of the results that we obtained in this trial.